Now, today we are discussing a very common viral infection that is called as dengue fever. Now, as far as etiological agent is concerned, dengue virus is the etiological virus for which causes dengue fever. Dengue virus is a single-stranded RNA virus. Say, viruses are two types, RNA and DNA. So, dengue virus is a single-stranded RNA belonging to arboviral family. That is, belongs to Flaviviridae family. It has four antigenically distinct serotypes. That is DEN1, DEN2, DEN3 and DEN4. DEN1, DEN2 were prevalent until 1980s. DEN3 is predominantly in recent outbreaks, and DEN4 primarily detected in secondary dengue infections. Serotypes provide specific lifetime immunity and short-term cross immunity. It will give a lifetime immunity, particular serotype. About the transmission of dengue virus, two general patterns are there. First one is epidemic dengue and second one is hyperendemic dengue. Epidemic dengue transmission is dengue virus is introduced into a region as an isolated event that involves a single viral strain in Asia, Africa and America most likely. And hyperendemic dengue transmission, that is a continuous circulation, say continuous circulation of multiple viral serotypes. As we have seen DEN 1, 2, 3, 4. So these are the multiple serotypes. So multiple viral serotypes is in area where a large pool of susceptible hosts and a competent vector are constantly present. Predominant pattern of global transmission. Now, source of infection is mosquito bite. Like in malarial fever, the malarial fever is also caused by a mosquito bite, and about dengue fever, it is also caused by bite of a mosquito. So, vector. The vector for this dengue fever is Aedes aegypti. Dengue fever is transmitted by infected female Aedes aegypti. Can be identified by white bands or scale patterns on legs and thorax. So, due to this scaling, it is also called as a tiger mosquito. It is primarily a daytime feeder. Profound in tropical and subtropical regions, live around human habitats, lay eggs and produces larvae preferentially in artificial container and clean water. Vector and its transmission. This slide shows the vector of this dengue fever and the mode of transmission. Now, replication and transmission of dengue virus. When the mosquito bites, virus inoculated into a human being with mosquito saliva. That is, the virus is in the saliva of the mosquito. The virus localizes and replicates in various target organs, local lymph nodes and liver, and released spreads through the blood, infects the WBC and reticuloendothelial system, that is dendritic cells, hepatocytes and endothelial cells. The mosquito ingests blood containing the virus that replicates in the midgut, ovaries, nerve tissue, fat of the mosquito, fat body of the mosquito, and it is then escape into the body cavity and later on infects the salivary gland. So viral replication occurs in midgut, ovary, nerve tissue and fat of the mosquito. Then it escapes into the body cavity. Later on it goes to the salivary gland, and in the salivary gland the viral starts replicating. When the mosquito bites another human, the life cycle continues. Human are the primary reservoir of infection. Vector. Now, as far as vector is concerned, Aedes aegypti and another one is Aedes albopictus. These are the two vectors. The female mosquito feeds on blood. They need the protein found in blood to produce eggs. Male mosquito feed only on plant nectars. The mosquito is attached by the body odor, carbon dioxide and heat emitted from the animal or humans. Now, as far as the life cycle of this Aedes aegypti mosquito is concerned, the eggs are laid on the walls of water-filled containers in the house or patio. The eggs can survive for months and hatch when submerged in water. Female mosquitoes lays dozens of eggs up to 5 times during their lifetime. The mosquito life cycle takes 8 days and occurs in water. Adult mosquitoes live for 1 month. Adult mosquitoes usually rest indoors in dark areas, closets, under beds, behind curtains. Only female mosquito bites humans, not males. The dengue mosquitoes can fly several hundred yards looking for water-filled containers to lay their eggs. The dengue mosquitoes does not lay eggs in ditches, drainages, canals, wetlands, rivers or lakes. Now this slide is showing the Aedes aegypti mosquito. See the white bands on thorax and white bands on the legs of the mosquito. It looks like a tiger mosquito. See this is the picture of Aedes albopictus. Now, as far as pathophysiology is concerned, a rapid activation of the complement system occurs. Blood level of soluble TNF receptors, that is tumor necrosis factor, interferon gamma and IL-2, that is interleukin 2, are C1q, C3, C4, C5 to 8 and C3. Proactivators are decreased. These factors interact at the endothelial cells to produce increased vascular permeability through the nitric oxide final pathway. See this diagram, this flow chart suggests that dengue infection occurs antibody formation, reinfection, augmentation of virus multiplication. In one side, increased vascular permeability, plasma leakage occurs, hypovolemia and shock and ultimately death. This is the one cycle. Another one is reduced platelets, coagulopathies, disseminated intravascular coagulation, severe bleeding and ultimately death. So this is the cycle of dengue infection. Now, as far as clinical manifestations are concerned, there are 4 clinical syndromes in dengue fever. First one is undifferentiated fever. Second one is classic dengue fever. Third one is dengue hemorrhagic fever, that is DHF. And fourth one is DSS, that is dengue shock syndrome. This DSS is a most severe form of dengue fever. Most of the deaths are there in this dengue shock syndrome. Now, first one is undifferentiated fever. Most common presentation is silent transmission. The incubation period is 3 to 14 days. Average is 4 to 7 days. Sudden onset of fever. The fever pattern is biphasic. Severe headache, preferentially retroorbital. The patient usually complains, when came to you, usually complains of retroorbital pain. That is, when we press the eyeballs, the patient complaining of the pain. This is the characteristic feature of dengue fever. Now, myalgias, arthralgias, that may be severe. Nausea, vomiting, rash may be present at the different stages of illness. Maculopapular, facial erythematous, hemorrhagic manifestations are there in dengue fever because of the coagulopathy. Now, dengue hemorrhagic fever. In dengue hemorrhagic fever, usually develops around 3rd to 7th day of illness. There is rapid onset of plasma leakage, as we have already seen in that cycle. There is rapid onset of plasma leakage, altered hemostasis and damage to the liver, resulting in severe fluid losses and bleeding. Skin hemorrhages, patches, purpuras, ecchymosis, these are very common. Gingival and nasal bleeding as well as hematuria. GI bleeding, hematmesis, melena, hematochezia, these are also present in dengue hemorrhagic fever, that is DHF. Plasma leakage is due to increased capillary permeability. Manifest as hemoconcentration because there is leakage of plasma through the capillaries. So, it manifests as hemoconcentration, pleural effusions and ascites. The fluid fills the body cavities. Bleeding due to capillary fragility and thrombocytopenia. Liver damage manifests as increase in liver enzymes, low albumin levels and deranged coagulation parameters, that is PT and PTT, prothrombin time. Now, 3 phases of dengue hemorrhagic fever. Febrile phase, 2 to 7 days, in which sudden onset of fever, severe headache, epigastric discomfort, anorexia, vomiting, arthralgia, myalgia, that is joint pains, arthralgia, myalgia means muscle pain, muscular pain. So, arthralgia, myalgia, flushing, tender hepatomegaly, splenomegaly, maculopapular rash. Leakage phase, first 24 to 48 hours, in which pleural effusion, ascites, pericardial effusion, hemorrhagic manifestations, hematmesis, melena, epistaxis and menorrhagia. So, in the body cavities, the leakage process fills the fluid in the body cavities. Now, convalescent phase, short and uneventful, return of appetite, bradycardia, recovery rash, severe itching on palms and soles. These are the signs of convalescent phase. Criteria to label dengue hemorrhagic fever. As far as WHO guidelines, WHO case definition of DHF, that is dengue hemorrhagic fever, fever with sudden onset 2 to 7 days, hemorrhagic manifestations with positive tourniquet test, low platelet counts, that is less than 1 lakhs per mm cubic or less, objective evidence of plasma leak syndrome, that is hematocrit equal to or more than 20% above the baseline, low albumin levels, pleural and pericardial effusions. Now 4 grades of dengue hemorrhagic fever: grade 1, grade 2, grade 3 and grade 4. Grade 1, fever and non-specific constitutional symptoms, that is positive tourniquet test is only hemorrhagic manifestation in grade 1. Grade 2, grade 1 plus manifestation, that is spontaneous bleeding. Grade 3, signs of circulatory failure, that is patient is starting the circulatory failure. Grade 4 is profound shock. In grade 3 the shock started, and in grade 4 there is profound shock, that is undetectable pulse, that is pulse is not recordable, blood pressure is not recordable, pulse is not palpable. Danger sign in dengue hemorrhagic fever. So danger signs in dengue hemorrhagic fevers are abdominal pain, that is intense and sustained, persistent vomiting, abrupt change from fever to hypothermia with sweating, change in mental status of the patient. These are the danger signs in dengue hemorrhagic fever, that is DHF. Unusual presentation of severe dengue fever, usually not presented. Unusual presentations, that is encephalopathy, liver failure or fulminant hepatitis, demonstrated by increased aminotransferases, increased bilirubin, increased PT and APTT. So all the enzymes are deranged. Cardiomyopathy, conduction defects and obviously myocarditis. Severe GI bleeding may be there. Now as far as risk factors are concerned, age, all age groups are affected. Pre-existing anti-dengue antibody either caused by previous infection or to maternal antibodies passed to infants. Higher risk in secondary infections. Higher risk in locations with 2 or more serotypes circulating simultaneously at high levels. Now, what is tourniquet test? Tourniquet test: inflate the BP cuff to a point midway between systolic blood pressure and diastolic blood pressure for 5 minutes. After deflating the cuff, wait for the skin to return to its normal color. Then count the number of patches visible in 1 inch square area on the ventral surface of the forearm. Positive test, that means 20 or more patches per 1 inch is positive tourniquet test. See, this diagram is showing the positive tourniquet test. Now, dengue shock syndrome, that is DSS. There are 4 criteria for DSS: evidence of circulatory failure, manifested indirectly by all of the following, that is rapid and weak pulse, narrow pulse pressure, that is equal to or less than 20 mm of Hg, or hypotension for the age, cold clammy skin and altered mental status, and frank shock. For laboratory test in dengue fever, first the blood count WBC is leukopenia, lymphocytosis, platelet thrombocytopenia, hematocrit equal to or more than 20% of the baseline. So there is thrombocytopenia, always platelet counts goes down, WBC goes down, that is leukopenia, and lymphocytosis. Now liver function test, the serum and aminotransferases are deranged, serum bilirubin increased due to hepatitis, viral hepatitis, that is dengue viral hepatitis, serum albumin is going down, that is low albumin. Coagulation studies, PT, APTT prolonged, serum electrolytes deranged, blood gases, metabolic acidosis, tourniquet test positive, complement levels low, blood urea raised, chest X-ray to see for effusions and ECG for bradycardia and prolonged PR interval. Serological diagnosis by ELISA, anti-dengue IgM and IgG antibodies, sensitivity 84 to 98%, specificity 100%. Heme agglutination inhibition test, complement fixation test, that is CFT, viral isolation, molecular detection, that is PCR. Now treatment is concerned mainly supportive, no hemorrhagic manifestation, and well hydrated patient sent home with instructions for follow-up. If hemorrhagic manifestation, hydration status borderline, patient observed in hospitals. If warning signs are present even without evidence of shock, or if DSS present, patient should be hospitalized. Intravenous fluids, that is IV fluid, should be given with electrolyte balance. Antipyretics, that is acetaminophen, aspirin, and NSAIDs should be avoided as they interfere with platelet functions, so can cause bleeding, so they should be avoided mostly. H2 blockers, antiemetics, that is domperidone, platelets and FFP transfusion when needed, monitoring of blood, urine output, platelet count and hematocrit. So monitor, you should have to monitor about the urine output, platelet count, blood pressure, all this to see for the shock and other complications. Soft and balanced nutritious diet. Now mosquito barrier needed until fever subsides to prevent Aedes aegypti mosquito from biting patients and acquiring the virus. So the cycle should be braked. Patient should be kept ideally in screened room or under mosquito net. Now treatment of DHF, that is dengue hemorrhagic fever and dengue shock syndrome. A medical emergency. This is a medical emergency. Patient should be admitted in ICU. Treatment of DHF and DSS. It is a medical emergency. Patient should be admitted in ICU. Keep the patient in supine position. Immediate evaluation of vital signs and degrees of hemoconcentration, dehydration and electrolyte imbalance. Rapid IV replacement with wide bore cannula. Normal saline is the ideal fluid of choice. Monitor for complete blood count, LFTs, that is liver function test, for coagulation factors, PT, APTT. When pulse pressure is equal to or less than 10 mm of Hg, or when elevation of HCT persists after replacement of fluids, plasma or colloid are indicated. FFP, fresh frozen plasma, and platelets for bleeding. No roles of steroids or corticosteroids is there. Look for evidence of complications. Avoid hypervolemia. Now, for complications, fluid and electrolyte losses, myocarditis, hepatic dysfunction, febrile convulsions, residual brain damage, encephalopathy, disseminated intravascular coagulation, that is DSS, dengue shock syndrome. Indications for hospital discharge. Indications for hospital discharge are absence of fever for 24 hours. If the patient is afebrile for more than 24 hours and his appetite returns, visible improvement in clinical picture, that is feeling of well-being, stable hematocrit 3 days after recovery from shock, platelet is equal to or more than 50,000, no respiratory distress from pleural effusion or ascites. Now return immediately to clinic or emergency department if any of the following warning signs appear: severe abdominal pain and persistent vomiting, red spots on patches on the skin, bleeding from nose or gums, hematemesis, tarry stools, drowsiness or irritability, paleness, cold clammy skin, and difficulty in breathing. Now for dengue vaccines, no licensed vaccine is up till present. Effective vaccines must be tetravalent. Field testing of an attenuated tetravalent vaccine currently underway. Prevention: vector control, that is chemical control. Larvicide may be used to kill the immature aquatic stages. Ultra low volume fumigation is effective against adult mosquitoes. Mosquitoes may have resistance to commercial aerosol spray. Biological control is largely experimental. Placing fish in containers to eat the larvae. Environmental control, elimination of larval habitats, most likely method to be effective in the long term. Prophylaxis, avoiding mosquito bites, use of insecticides, mosquito repellents, body covering with clothings, screening of house, destruction of the vector breeding sites, and using mosquito nets. If storage is mandatory, a tight fitting lid or a thin layer of oil may be prevent laying of eggs or hatching. A larvicide, that is abate, available is 1% sand granule formations, may be added safely to drinking water. Why to control? And purpose of control is reduce female vector density to a level below which epidemic vector transmission will not occur. The minimal vector density to prevent epidemic transmission is unknown. Now, program to minimize the impact of epidemic. Teaching the medical community how to diagnose and manage dengue, hemorrhagic fever. Educating the general public to courage and enable them to carry out vector control in their home and neighborhood. So these are the pictures showing common containers in which the egg develops into adult dengue mosquitoes. Recent advances: gene modified mosquitoes could stop dengue fever. Genetically modified mosquitoes we released last year at sites in Malaysia and the Cayman Island. Now, key messages are dengue infection is preventable disease, no direct person to person transmission, prevent man mosquito contact to prevent the disease. Thank you.